Starting shortly in maybe 1 minute.
Randir, have you opened both the links? We need to open 2 links. One for the question answer session. Randir?
Randir may be muted.
Kushal, are we live? It's live. Start.
Good evening, everybody, and welcome to this very important Indo-US webinar on 2 very common problems that we see in clinical practice: gastroesophageal reflux disease and irritable bowel syndrome. I am Nageshwar Reddy from Hyderabad, India, and co-chairing the session with me is Dr. Randir Sood from Delhi and Dr. Mahesh Goenka from Calcutta. We also have 2 very eminent speakers who will be introduced shortly, giving us talks on this area. We have 20 minutes for each talk, followed by 15 minutes question hour session. We'll start soon. We'll start first with Dr. Randir Sood, who will introduce Dr. Pratik Sharma first, and then go on with the program. Randir?
Yeah, thank you, Nagi. I think most of the people who are listening today won't need an introduction for Pratik because he has been here so frequently that we don't even know that he's staying in US. And Pratik hails from Baroda, but is professor of internal medicine at Kansas University Medical Center, and he's one of the most eminent gastroenterologists of Indian origin in US at present, and he was elected as the president of International Society of Disease of Esophagus last year. And to my knowledge, last I know is that he was the trainer of ASGE. He climbs up the ladder so fast that it is difficult to keep a track of his progress. So, and his main area of interest is esophageal diseases, and you will find his footprint in every recommendation and every classification on esophageal disease, be it GERD, be it Barrett's, be it endoscopic classification. You will have Pratik Sharma there. So it is our privilege to listen to Pratik directly, and he'll be talking about GERD and its management today. And welcome, Pratik.
Thank you, Randir, and really those are very kind words from you, and thank you again for saying them. And it's again my pleasure to be here and share the update esophageal reflux disease, and it's always a pleasure addressing it's a mutual relationship in which I learn from all of you as well. So that's what I'll be doing in the next 15 to 20 minutes. So let's just start initially with the definition of gastroesophageal reflux disease. And I think this is important because GERD is defined or is called in the local language by different names. Some people refer to it as gastritis. Some people think it's gas pain. The Montreal definition is one which takes into the patient's symptoms into consideration, and it's defined as a condition which develops when reflux of stomach contents causes troublesome symptoms or complications. So it takes both the patient perspective as well as the physician perspective. So if you find a peptic stricture, that's probably from gastroesophageal reflux disease. And if a patient comes to you to see you in clinic because they're having bad heartburn or regurgitation, then it's a troublesome symptom. So that's when reflux ends and the disease actually starts. So I think it's very important to figure this out. Let's spend a couple of minutes just discussing the epidemiology of GERD and looking at the global prevalence of something which is very common, as Nagi mentioned in his initial introduction. And this is the global distribution of reflux symptoms. And again, it's defined by weekly heartburn in this map. And you can see that if you're in the red, that's bad. And the lighter the color, probably you have a lower prevalence of gastroesophageal reflux symptoms. And you can see that purposely I've not marked India in a specific color because until very recently, since the GERD task force was developed by the Indian Society of Gastroenterology, and we shared those results at a national ISG meeting in Hyderabad, what we determined was that depending as to whether you were in the north, south, east, or west of India, which again is a huge country and different parts, different diets, etc., the prevalence varied from 8 to 15%. And you can see that this prevalence is also of weekly heartburn. And if you pay attention to the numbers at the bottom of the screen, these numbers are not that different. So one myth was that reflux disease is a disease of the West. And I think just as we are progressing as a nation in India, I think we are also unfortunately getting some of the symptoms and the diseases of the West as well. And you can see right from here as to what those numbers are. The other concerning trends are that the prevalence of symptoms are having been increasing over time. And we don't have good data from India about this because of the reasons I mentioned. But you can see that in the gray bars at the very bottom are the numbers from Asia. And also those are increasing over time, at least from the 1980s to 2010. And we don't have good data on time trends since 2010 for the world, but you can see here that the prevalence has been increasing over time. And so it begs the question, what are the reasons for this? And has this changed in 2020? So this is something really hot off the press. This is actually an article which is in press in gastroenterology right now. This is a large population-based study in the US, and they were able to get close to 70,000 respondents. And based on this, you can see that the prevalence of reflux, however you define it, any reflux symptoms over their lifetime, 44%, any reflux symptoms within the last week, 30%, and troublesome GERD, according to the Montreal definition, 18%. So you can see that in 2020, those numbers, even in the US, despite recognizing this disease for decades, they continue to increase, or at least they continue to be prevalent or highly prevalent in the society. So what are some of these reasons that this is happening globally? Is it the aging population? Is it an increasing prevalence of obesity? Are we using drugs which impact the LES pressure or gastric emptying? Are we more aware of this disease and there is more self-treatment and access to over-the-counter medications, and that's the reason the patients report more of these symptoms? Or is it dietary habits or other lifestyle factors which may be contributing to the increasing prevalence globally, but specifically in India? So I think we should be discussing this more often in India about how can we get our handle around this increasing gastroesophageal reflux disease. One thing is clear is that as the BMI increases, reflux symptoms increase. And out of all the different studies, I did decide to highlight this because just as in the US, now I see that there is an increase in BMI in India as well. So Randhir mentioned that I'm there quite frequently, and it's because of friends like Nagi or Mahesh or Randhir who, invite me and I visit India. And one thing which does strike me is the increasing obesity in India. And this is a study published in the NEJM, New England Journal of Medicine, almost 14 years ago. But I bet you that if we were to do a similar study in India of obesity and reflux symptoms, we would find a similar correlation. And what was very striking about this study is that it showed that even moderate weight gain, which was defined as a gain of 2 kilos in a normal person, can also cause or worsen reflux symptoms. And on the flip side, the good news is that this is a modifiable risk factor. Weight loss has been associated with a reduction in symptoms. So I won't discuss that as a treatment management, but just something to keep in mind. So let's switch gears now from now knowing how do you define this disease, how common it is, and it's increasing in India. So what can we be doing about it? And what are the different therapies? So I'll just spend a few slides on each one of them. So one thing is quite clear, and you will see that some of these references are from 1997, because that's when some of these initial PPI studies were done. And I think there's no question about it that they provide the most effective healing in patients with reflux disease, so healing of esophagitis. And they also have consistently been shown to improve patients' quality of life. And you'll hear from Satish about IBS, in which the main outcome is improvement in quality of life, because that's what's driving that disease. And similarly, both these diseases we are discussing today are symptom-driven disease, and so improvement in quality of life should be a major endpoint we should be looking at in studies. And this is how PPIs compare to H2 blockers and to placebo. Please note that the healing of 90% is for healing of the esophagitis or the inflammation seen on endoscopy. If you look at symptoms, that same number from 90% drops down to about 50% or 60%, and I'll show you some patient-driven symptom data along with that. They're also efficacious for long-term. That was 6-month data I showed you. Here's a study from Lars Lundell at 3 years, which was then extended to 5 years, and it showed that you can keep esophagitis healed by switching the doses of PPI around for up to 5 years of therapy. So that's medical therapy. How about surgical management of gastroesophageal reflux disease? Should we be sending all GERD patients for anti-reflux surgery so that they can be cured of the disease? And again, the best way, obviously, to look at this is by looking at RCTs, or data from randomized controlled trial. This is the Lotus RCT, which was laparoscopic anti-reflux surgery or Nissen fundoplication, LARS versus PPI therapy, which was published in JAMA a few years ago. This is a Scandinavian European study, and you can see it's a very well-conducted multi-center study, patients randomized with reflux disease to either anti-reflux surgery done in expert centers or to PPI therapy. What are the findings? You can see that remission of reflux is quite similar between the two entities. Heartburn control or persistence of heartburn is also similar. Surgery is more effective in controlling reflux symptoms or regurgitation, as is shown here, that it was persistent in only 2% of patients with anti-reflux surgery and 13% with PPI therapy. And we can discuss that. This is probably because these patients with regurgitation have large hiatus hernias. On the other hand, anti-reflux surgery gives rise to new symptoms, such as dysphagia, gas, and bloating, which is not there in the PPI arm. So you could make one symptom better, but unfortunately, in 10% of the patients, there may be dysphagia. And in about 30 to 40% of the patients, you may give them a new gas bloat syndrome because of anti-reflux surgery. So something to keep in mind and discuss with your patients with that. So what do at least the US guidelines say about surgery for gastroesophageal reflux disease? Which is fair statement that surgery is a treatment option for patients with chronic gastroesophageal reflux disease. This is a very important second bullet, which I think this guideline had about 10 recommendations on surgery, but this is, I think, the most important one, is that surgery should not be recommended in patients who do not respond to PPI therapy. So that's a key take-home message today for it. A few words about endoscopic management of gastroesophageal reflux disease. This is looking at the Stretta procedure, which you're all familiar with, radiofrequency ablation of the lower esophageal sphincter. I think we've shown this at multiple courses in India, and all our moderators are experts in this. And at each of their live courses, you've all seen this, in which you can create these different burns in the region of the gastroesophageal gastroesophageal junction. There is remodeling of the lower esophageal sphincter, and that burning in turn leads to improvement in gastroesophageal reflux disease. This is the TIF procedure, also known as esophax, and this stands for transoral, minimally invasive, or incisionless fundoplication. So the concept is that, can you do a fundoplication, which is done laparoscopically by the surgeons? Can we do it endoscopically through a minimally invasive way or through a transincisional cyst way? And this is the TIF procedure, or the esophax. So these have been around for almost a decade now, both these procedures, and you can see the sutures going in, the pledgets are put in, and you can do either 1, 2, or 3 pledgets in that area. And what it does is that it is a serosa to serosa apposition. 3 are placed there, and you can see post-procedure how it is supposed to look. So some of these procedures are there, and they have been around for a few years. So having said that, if everything's great, what are the unmet needs? Why are we still talking about gastroesophageal reflux disease? So let's look at that. Things are not that rosy. These are data from 2010 or 2008, and these are US data. And what this shows is that about 35% of patients on PPI therapy said that they continued to have symptoms. So just keep note of these data from 2008. 42% of patients with PPI therapy said that they were either taking twice daily therapy and they were adding another medication, or they were taking a second non-PPI medication in order to control their symptoms. So these are US data. Now let's compare again in 2008, similar data of American patients compared to the Asian Pacific region, including India. And you can see that if you look at nocturnal symptoms, need for additional medications, a second non-PPI medication in order to control their symptoms. So these are with the current PPI therapy. Now let's compare again in 2008 patients and the Asian similar Pacific data patients, of American patients compared to the Asian Pacific region, of patients felt satisfactory. And you can see that therapy, which was there in 2008, which was PPI therapy, need for additional medications. Half of these patients are still using additional medication in order to satisfy. So these are whether it's prokinetic agent or something, but they're still not satisfied with their current therapy. Similar data. Now, coming back to the study which is in gastroenterology from the US, let's focus on what those numbers are in 2020. Therapy, which was there in 2008, of the 72,000 population in the US. 40% of them were taking therapy. And you can see what type of therapy they were taking, with almost something more than half of these patients on PPI therapy who were taking it. Coming back now, if you ask them how many of those on therapy had symptoms, 60% of them still had persistent symptoms while taking their PPI medication. And what were these symptoms? Either heartburn, either regurgitation, but the most common and 50% of them were both heartburn and regurgitation. So yes, so even though the data in trials looks great, when we start talking to patients, they're actually not that satisfied and they're still having consistent symptoms. So what are the factors which were associated in the study with PPI refractory reflux? Female gender and young age stood out. Latino race was, of course, there in the US, but I bet you that if you did a similar study in India, you would notice the same thing. That younger patients, as well as women, symptoms of reflux may be more difficult to treat or control in that patient population. Finally, a few words about the risks and benefits of PPI therapy. And here I've just listed a number of these different concerns that the patients may have about their therapy. And we've heard about C. diff infection, dementia, fractures, etc. So that's another concern. This was a survey done in the US last year, close to 800 patients, and they were asked about what are your concerns with PPI therapy. And you can see that anywhere from 10 to 20% of these patients had some concerns about therapy. So I feel another unmet need is better patient and physician education about this risk rate. Most of the patients are not that high, and I think that is another unmet need for it. So I've defined two unmet needs. One is controlling patient symptoms, the other is risk that the patients receive. So is there anything new? I think the first thing, the new thing we have on endoscopic therapy is the full thickness plication, which is also called the GERD device, and this is the AIG trial, which has been submitted for publication. And this is a randomized controlled trial looking at improvement in GERD-related quality of life score, and you can see that it was significantly better in this new device as compared to the sham trial. So this new device definitely holds promise as we move in this field of gastroesophageal reflux disease. The other one, which also is just in press right now, is what's called the anti-reflux ablation. And this is a study from South America, which is also in press in GIE. So I thought I'd share some of these newer data. And this is using hybrid APC, very similar to the armed procedure that Inouye was doing, which I think really has not panned out. This is also creating an injection, injecting into the submucosa, and then doing a 270-degree burn in the area of the gastroesophageal junction, and again remolding this area in this situation. And this is being done right now as we speak. And this was the first study which showed that at 3 months there was improvement in acid exposure time as well as health-related quality of life. So something, both these devices we should be watching out for. How about medical therapy? What's new in the horizon for it? One is changing this formulation of PPI. So this is called the DDR technology. So DDR stands for dual delayed release technology. And this is one of those technologies in which the PPI is released at 2 different time points. So let's look at how the pill looks like. So it combines 2 different types of enteric cortex granules, which are shown there. And I've just used 2 different colors just to highlight the concept of how this works. Release 1. This is where most typically PPI is released. It releases 25% of the granules at a pH of 5.5 within the first hour or 2 of the patient taking the medication. What's unique about this technology is that the second release happens in the ileum, and that comprises of 75% of the granules at a pH of close to 6.7, and this happens 4 to 5 hours after the patient has taken the pill. So what are the advantages of this? Is that number 1 is, for some reason, if there was not good absorption initially, you still have that second phase. This extends the plasma concentration and the pharmacodynamics of the drug. And studies have shown that this increases the duration of action of the PPI. So rather than patients having to take it twice a day, once daily therapy with this DDR technology can also help you and can increase the duration of action of the drug. So DDR technology and dual delayed release technology is something there. The second thing which is good, and also very new, which was published in Gastroenterology 2 months ago, is a bile acid sequestrant. And this was a randomized controlled trial of taking patients who were on BID PPI therapy or QD PPI therapy and then adding the bile acid sequestrant to it for reducing bile reflux. This showed modest results, and you can see that the best results were in those who took 1,500 milligrams of that drug, which is a high dose and is 4 big capsules which need to be taken, but something else which is on the horizon. So hopefully I've shown you in summary that the prevalence of reflux is increasing globally, and specifically in India, we should be paying close attention to this. Symptoms are the mainstay of GERD diagnosis as well as of treatment. Currently, PPIs are the most effective medical therapy, but symptom control with the current classic therapy is an issue, and patients have shown you are not satisfied with the current therapy. A variety of novel technologies, including this EDR technology, bile acid sequestrants, as well as some of these new endoscopic therapies are emerging, and I think they will help us in improving GERD management. Thank you all very much.
So, Pratik, for as usual, a very lucid and elaborate talk. I know that I've been seeing on the dashboard there are plenty of questions which have come up. Just to set the ball rolling, Pratik, when you say that almost 40% patients are not satisfied with the usual once-a-day therapy, and almost 22% patients are taking twice-a-day therapy and still not fully satisfied. What are your views? Because this is very relevant to India. Because Indian pharmaceuticals have combined prokinetics with PPIs, and these are being promoted and prescribed for GERD, and it is being prescribed left, right, and center in spite of the potential for harm. What are your views about it?
So yes, thank you, Randy. I think that's a very important question, and if I can share both sides of the ocean here with you. So in the U.S., as you know, prokinetics for GERD are not recommended at all, and in fact, it's very difficult to get prokinetics in this situation. Cisapride, which was available, is no longer available. So the studies, if you are a purist and you go just by evidence, there really is no evidence of the currently available prokinetics that they work, because number one, they've not been tested in GERD, and more importantly, they've never been tested as add-on therapy, the way they are being sold in India, and that they are commercially available and things like that. Side effects are an issue with that, and I think Satish may go into a little bit detail about those also for his presentation too. So that's if you look at pure studies and clinical data, that's what I can tell you is that there aren't any good clinical data to do that. But when I'm in India, and Randeep, maybe I would like to definitely hear comments from you and Nagi and Mahesh on that, because when I have that same discussion with the physicians in India, including yourself, a few things. Number one, they are commercially available, and patients do take it. And I think you hear, again, anecdotal episodes of patients being improved on that therapy, which of course is never scientific information, but patients are satisfied. So, I mean, I'll ask you is, I can tell you from the studies in the US, there really is no evidence that they work. You could make a case for those patients who have documented delayed gastric emptying. So if you have a diabetic who has gastroesophageal reflux disease as well as dyspeptic symptoms or early satiety, I think you can use a combination therapy. It makes sense because there are studies that prokinetic helps the diabetic symptoms, and there are studies that PPI helps the GERD symptoms, so maybe you can use that. If patients have some of those symptoms, you can try it, but otherwise I don't see a major reason to do that. But seriously, I would like to get input from the three experts from India who are on as to what is your sense, because I think it's a very important and relevant question.
We normally limit its use to patients, as you told, of delayed gastric emptying or patients with volume reflux, that's regurgitation. And, they for a limited period of time. The problem is that none of the prokinetics have a long-term safety, and they have 35x's been taken for a long time.
Now, do you have comments on that?
No, actually, I agree with Ranjit. I think basically, theoretically, they're good for those with gastroparesis, elderly, or those who have diabetes and so on. But if you look at the physiology, it's not increased acid, and we're just suppressing with PPI. It's just that acid that's coming into the esophagus is not being pushed out adequately. So I think there's a physiological basis for using this prokinetics. But unfortunately, although it's used very widely in India, we don't have good randomized studies to support it. And that's the reason why I think it's not gone into literature, especially because this combination drugs is something that's not encouraged in the West. But in Indian prescription, if you see, if PPIs are not effective, the immediate next thing that here gastroenterologists go into is use a combination of the prokinetic with PPI. And of course, anecdotal experience to say that it's helpful. But I think, as Pratik, you rightly said, we have to have good randomized control studies to prove this. And I'm not sure why it's not been done, but I think we should do that to show rest of the, because this combination is not available in the rest of the world commonly. That's one important.
Pratik, I'll rapidly go into the dashboard, which has got plenty of questions for you, so that we can finish in time. We have first question from how do I minimize it? Which is the, can you hear me now?
Yes, please.
Yeah. So first question is, which is the best molecule for treating, this is for IBS, and we can finish in time. We have Dr. Thirumal is, our thought was PPI bonds more in morning before food and near delayed release, how will that work? So that's a relevant question which actually needs to be answered, because this GDS technology, because it's an irreversible binding to the proton pumps. So how does this remain effective after initial few days?
Right, it's a good question. So again, as you know, the regular PPIs, all these PPIs should be taken, half an hour before meals. What the studies in the US with the dual delayed release technology showed, again, and this is data from scientific studies, was that the patients, they queried patients about when they actually ended up taking it. And what they found out was that if patients were taking these pills with the DDR technology, even with the meal rather than before the meal, they had similar symptom control to do that. The other question, I think what they're trying to ask is it better half an hour before breakfast, or is it better in the evening time? And you should go by patient symptoms. So if patient symptoms are mainly during the day, you should take the pill, should be recommended to take in the morning before breakfast. If the patient's mainly having nocturnal symptoms, then I think it's very reasonable to take the PPI or the GERD medication before the dinner time. So the reason we always are stuck on the breakfast time, because that's how the RCTs were conducted. But the concept is that it should be taken before a meal, and if they're mainly nighttime symptoms, you can take it before dinner.
So next question is by Dr. Prakriti Shah, why surgical management is not useful in patients who have failed medical therapy?
So that's an excellent question. And the reason I emphasized on that is because that's a patient group that probably does not have reflux disease, okay? So I've shown you the data on PPIs. And so what happens is that if you have a patient who's taking a PPI and they have symptoms which are not improving at all, it's probably not gastroesophageal reflux disease. So that's a patient population you really want to work up with an endoscopy, with a 24-hour pH monitoring to make sure that the patient does have acid coming up, because otherwise the fundoplication is going to give them additional symptoms but is not going to treat anything else.
So next question is by Dr. Shrikant. How do you manage a case of patient with persistent heartburn despite PPI?
Right, so good question. So, that obviously the refractory GERD talk is a whole separate talk in itself. So you have to look at three components whenever you have patients with persistent symptoms. One are patient factors. Is the patient compliant with the therapy? Is the patient taking the medication as prescribed by you? And I think those are two important patient factors which are there. The second bucket is, have you suppressed the acid adequately? And if you haven't suppressed the acid adequately, then you can either increase the dose of PPI, you can put them on a PPI with a DDR technology, you can consider surgical management, you can consider endoscopic treatment. So that's another bucket. The third bucket is this patient having irritable esophagus? So it's like an IBS of the esophagus or hypersensitivity esophagus. And again, for that, you probably need further testing, which is a pH impedance testing. And then you treat those patients accordingly. The last bucket is that there is no acid or bile coming up at all, and it's not GERD. It's either dyspepsia, H. pylori, peptic ulcer disease, but it's not GERD. So those are the ways, again, and that's a huge topic in itself, but those are sort of like the buckets you should be thinking of when you're faced with a patient like that.
So Pratik, the questions in front of me are multiplying like COVID in India, but I'll be combining certain questions and only asking you questions which are totally different. So, one question is, which is often asked and, has no clear answers, which PPI has the least interaction with clopidogrel?
So, I mean, I'd say that you can, based on the scientific data, you can't say it because there have been multiple studies which have been published now, and in fact, you can even question that interaction, right? Because it's there, but it's not that significant. So the initial hype that was there about clopidogrel and PPIs, in which there was this madness that every patient who required a PPI started stopping it. I think we have reversed that. We have shown that yes, in some patients it can happen. It had to do with those patients who were slow metabolizers of the drug, in that it potentially could happen, but that risk is absolutely very small. Then they tried to slice and dice the data by saying, is one better than the other? And, again, I have no conflicts with any companies, but I can tell you that go with the one which helps the patient.
So, Pratik, there are some questions which have already been answered during your talk. I'm not taking like role of bile reflux in GERD, endoscopic treatment options available for GERD. So the other question is that when we should do 24-hour pH manometry in GERD?
Okay, yes, good. So I think there are a couple of reasons to do it. Number one is if you have a patient, who is not responding to PPI therapy. The question then comes up is, should you do the 24-hour pH on therapy or off therapy? And this is a very relevant, clinically relevant question. And I think you have to take the patient into consideration. If your question you are asking is, does this patient have GERD? And you want to document any amount of abnormal acid reflux, then you should do it off of therapy. So the scenarios for that would be, if you're considering your patient for surgical management, then the pH metry should be done off of therapy. If you're trying to get your patient endoscopic treatment for GERD, then it should be done off of therapy. The third is when you've started a patient on a PPI and there is very minimal response to the PPI therapy, I would question whether this patient has GERD. And in that scenario, the pH metry should be done off of therapy. So those are the scenarios there. Now, there are scenarios in which the pH metry should be done on therapy, and that's in a scenario when the patient has response to therapy, but the response is inadequate. And if you're trying to document that, is this amount of therapy adequate to suppress all the acid, then the 24-hour pH monitoring should be done on therapy.
So, Pratik, the last question before we wind up is a very common question, because these days, every cough which goes to an ENT surgeon, they label it as the GERD. Right. So, this is Dr. Usha Subramaniam from Delhi who is asking, can GERD be a contributing factor for chronic dry cough?
Yes, so the short answer is yes. And a little bit of the long answer is that always be careful about, laryngopharyngeal reflux, ENT manifestations and GERD being the sole contributor. There are many, reasons for having cough. There are many reasons for a sore throat. There are many reasons for having hoarseness of the voice. GERD is a contributor, but not the only thing. So if your patient with chronic cough does not respond to PPI therapy in a month or two, then probably GERD is not the contributor. And I'll just leave you with one final sort of a study which was done at the Cleveland Clinic, in which they took patients who had, redness in their throat, and they had ENT physicians do it and gastroenterologists look at it, and both of them had different diagnosis. On the other hand, they also had ENT physicians do laryngoscopy in the general population, and they found that 30% of them had redness in their larynx. So these are common findings during ENT examination. Don't blame all of them on gastroesophageal reflux disease, because then you will think that PPIs are not working.
So, thank you, Pratik. I think we'll wind up there because we have Suresh waiting, and we need to listen to his talk. So over to you. I think Pharma has some presentation now and before the next talk. Thank you, Pratik. Thanks a lot.
Thank you. I think we'll go on to a short video presentation now before the next presentation. So if Joseph, you can have that on, then we can go on to the next presentation.
Answers.
Yeah.
So I think just finishing the video is just finishing. We'll wait for a second and then. Yeah, the video is just finished. Thank you. We go to the second presentation again on irritable bowel syndrome, and Dr. Mahesh Goenka is going to use.
Good evening to one and all.
Thank you, Nagi.
20 years, Sun Pharma has been not only the pioneer, but leader in gastroenterology and hepatology space. We've been able to bring you an unmatched product range and a consistent scientific engagement through 3 teams called Sun, Solaris, and Cygnus. Today, we are happy to present to you a 4th team on the field, Sundreon. So we can now go back to the second part of our.
So, good evening, everybody. And the first presentation evoked a lot of responses, and I can see almost about 100 questions, and we could take up only some of them. I'm sure the second presentation is going to be equally lucid and we'll have many, many questions because the topic again, though it's the other end of the gut, we'll be talking now about the lower GI, large intestine, and we'll be talking about irritable bowel syndrome. And we have another legend, Dr. Satish Rao. Many, many questions because the topic again, though it's the other end of the gut, we'll be talking now about the lower GI, lower intestine. I think there is a lot of echo, but let me continue. So Dr. Satish Rao, who is from Medical College of Georgia, from Augusta University, USA, he has been visiting India also very frequently and had gotten hosting him very recently in Asia Pacific Digestive Week held in Kolkata in December, before the COVID started. And Dr. Satish Rao is an expert in motility disorders, in functional bowel disorders, anorectal disorders, in bacterial overgrowth, all these very complex disorders. And when you'll hear those who have not heard him earlier will know how he converts a very complex subject into very simplified aspect, gives a very simplified aspect. So let's hear Dr. Satish Rao. The topic today is irritable bowel syndrome, which just like GERD is a very common prevalent disease. Dr. Rao, please.
Thank you, Mahesh. Sorry, let me maybe I need to unmute myself. Let me see that.
You are unmuted, sir.
So, good evening, everybody. Thank you very much to my very good friends, Dr. Nagi Reddy, to Dr. Mahesh Goenka for that lovely introduction, to Randhir Sood, and of course, to Pratik for that outstanding presentation. I'd like to thank Sun Pharma for allowing me to share with you some of these new thoughts as we discuss this new issues related to irritable bowel syndrome. It's very unusual to do this kind of presentations now in this new world, sitting in front of a television without any live audience. But there you go. That's the new world we live in. But with that said, let me move on to my presentation. So the objectives that I've set forth is to try and define IBS, as this is very confusing for most people. Unfortunately, when we cannot diagnose a GI problem, we put it in this box of IBS and we don't know what it is. Hopefully, let's try and elucidate some of those issues. We will try and briefly review its epidemiology, and particularly I'm going to focus on the pathophysiology of IBS. We will also try and look how can we diagnose this problem in the clinic? What are historical features of this condition? Is there anything new that each one of us can do to improve our ability to obtain a better history? We will look at diagnostic tests briefly, and the bulk of the time we will spend on really novel treatments for IBS. So here is the epidemiology. The prevalence, just like Pratik shared with you, the prevalence varies between 10 to 15% in the population, but this is key. Over 3/4 of patients remain undiagnosed even today. A third of them have had symptoms for more than 10 years, which has not been properly diagnosed. And again, another over 70% have symptoms that have never really changed. In other words, this is not a waxing and waning disease in the majority of the patients. It is a persistent disease with an annual incidence of about 1.5 to 2%. The bulk of these patients are in their most productive age of their careers and lives, 25 to 54 years, where the real action is in our lives. You know, we get jobs, we are finishing higher education, we're getting married, we have had children, and we have new responsibilities in our lives. That's when we see this problem. So it devastates the quality of life, and that is what we have to recognize and manage in this condition. Generally, it affects more women than men, although studies in India are one of the exceptions where men equate women in this risk factor, and there are many other things. But the main thing to remember is effects on quality of life. Let's begin with a story because I think that brings to home what exactly we're dealing with. I'm going to use 3 different case scenarios in this talk. First is this. A 42-year-old lady presents with symptoms of bloating and constipation for 10 years. She has between 1 to 3 bowel movements per week, and that too only after excessive straining. Intermittently, the patient reports left lower quadrant cramping abdominal pain. She is very worried about unpredictable and irregular bowel habit, and that is really causing significant anxiety for her. She also notes that certain foods can trigger her symptoms. Because of this, she can't eat out at restaurants. In fact, we are not able to eat out in restaurants now because of the COVID, but that's another scenario. This patient can't eat at restaurants. She tried certain diet restrictions, gluten-free, lactose-free, without much success. Her doctor asked her to increase her fiber. She used psyllium. It really didn't help. If anything, it made her bloating worse. She did not try some other important diets like FODMAP diet. She tried over-the-counter laxatives. She also tried PEG, again recommended by a physician. That really did not do. So when you're faced with this kind of problem, so you saw how we try to tease out her symptoms and really get to the bottom of the problem. Now, that kind of history, although I sum and a half or less, it actually takes a good 30 to 40 minutes. So we really have challenges with history because everybody's in a rush to see these patients and get them out of the clinic. The quickest thing we do as gastroenterologists, often we say, okay, you've got symptoms of dyspepsia or IBS or colonic symptoms, diarrhea. So let's go ahead and do your endoscopy. Fair enough. You do your endoscopy or you do a blood test. They're negative. Then what? You've never really taken a proper story from these people. So really, we have challenges with history because patients' recall of symptoms is very poor. And how we obtain history in clinical practice is very operator dependent. You as a physician clearly determines what kind of story you want to extract from your patients. And in the neurogastroenterology motility field, let me tell you, my friends, the most important thing is truly a good story, good history from the patient. So how do you really obtain this kind of prospective symptoms? And for that, a good stool diary is important. So today, I think there are a couple of stool diaries that I would like to introduce you to. One is the constipation stool app that I believe will become available stool in the App Store or Google Store, whatever. There's already an app for fecal incontinence symptoms using the FI stool app. Now, here is a little glimpse of this 10 questionnaire app. It asks the patients to rate their stool consistency, ask them whether they had a bowel movement, whether they have a feeling of complete evacuation, whether they're straining excessively, whether they have to use fingers. And then it generates a very simple report that is useful both for the patient. You can have a weekly diary or 2 weekly diary. This can be emailed to the physician or can be brought to the clinic. And this kind of a prospective diary can have a significant impact in our understanding. We were going to present this at DDW this year, but again, that meeting got canceled. Here is some of the validation that we did. I'm not going to spend too much time on this, but just to tell you that we did a week-by-week validation as well as comparative validation against a paper form prospective diary. Suffice to say, the intra-class correlations were very, very good, both for comparing against the paper form and for the first and second week trial. The other interesting thing about this app, and I'm going to now use 2 hats, my clinician hat, which is what I already talked to you about. There is also a research module that is very helpful for those youngsters who are listening and who really want to do research, because this is another area where you can get a very detailed report of this, and you can actually reorganize this research into baseline period, end of study period, or an option study period, and you can get raw data scores that you can export into Excel spreadsheets, and you can use this very usefully for your research. So some real advances in improving our ability to take good history, document the problems, and then really try and use this data both for information and guiding management as well as for research if one wants to choose. But one of the key things in your history that you want to find out is whether the patient you're seeing in your clinic today has any of these alarming features. Is this patient presenting for the first time after the age of 50 with these symptoms? Is there any suggestion of GI bleeding or iron deficiency anemia? Are these symptoms happening at nighttime, particularly diarrhea? Is the patient having any weight loss, or is there any family history of organic disease such as cancer, IBD, and celiac sprue? If these are present, be cautious about making a first-time diagnosis of IBS. You really want to think hard, is this really IBS? But make sure that if there are alarming features, investigate the alarming features first, only then diagnose this condition with confidence. So what other tools do you have? Well, we'll just focus on Rome 4. I think that is the latest tool. The main difference here was in Rome 3, we used to say pain or discomfort. We've recognized that discomfort is really a very vague term that patients find it very hard to describe. So Rome 4 really emphasizes on abdominal pain. So if a patient has recurrent abdominal pain, and this is important, at least 1 day per week for the last 3 months. So once a week, recurrent pain, number one. Number two, along with the pain, there are some changes in bowel function. The pain may be related to defecation before, during, or after, associated with a change in stool form. We'll talk about that, and associated with a change in stool frequency. Only then that you will confidently diagnose a patient as having IBS in the clinic. This Bristol stool scale has come of tremendous use in classifying their symptoms. So if a patient predominantly, that is 25% or more of their bowel movement, reports a type 1 or 2 Bristol stool scale stool, then that individual most likely has IBS with constipation. If again, predominantly most of the time it's 6 or 7 stool, it's diarrhea. If it is flipping and flopping between the two, it's mixed. And then you have a last subtype, which is undifferentiated, unclassified. Let's briefly look at the mechanisms that contribute or cause these factors. This is multifactorial problem. It's not a one-factor disease. There are host factors, luminal factors, and environmental factors. Let me just start with environmental factors because this is how generally IBS is attributed to, psychological distress. Let me tell you that all of my patients are distressed. Well, in fact, a lot of my physicians are distressed right now. That doesn't necessarily translate into IBS. Yes, when you have a disease that nobody's able to diagnose or give you comfort, you are going to get psychologically distressed, especially if you have had 10 endoscopies and 10 colonoscopies and you still don't know what it is. So, but that is not necessarily the driving reason for development of symptoms. It is a cofactor in the pathogenesis of IBS. Food is an important thing. Enteric infection, particularly post-viral infection, can trigger IBS, and that is an important cause. Luminal factors. We now recognize that the gut microbiome is a key feature in a number of even non-GI disorders, let alone GI. But clearly, IBS will develop if there is gut dysbiosis. Bile acids we have now recognized as a key mediator, particularly for IBS diarrhea. We all know that 95% of bile is reabsorbed in the TI, and if more than 5% spills, it can give you diarrhea. So important bile acid in diarrhea. But then there are a number of host factors that includes altered motility, slow motility in constipation, rapid motility in diarrhea. But really the key is the visceral hypersensitivity with altered brain and gut interactions. Also, there is evidence for gut immune interactions, increased intestinal permeability, and some genetic factors that can all predispose the host for developing these symptoms of IBS. As I mentioned, the key dysfunction, if there's one thing you want to remember, and that is that patients with IBS are hypersensitive. Here is an example where we distended a balloon in the rectum in control subjects and in IBS patients. And you can see IBS patients experience pain at much lower thresholds, whether it is pain or discomfort, much, much lower compared to healthy controls. They are hypersensitive. In terms of diagnostic testing, if you can categorize them into the 3 groups, IBS diarrhea, then really a CRP or fecal calprotectin can be useful to identify any inflammatory changes that may be the cause. You should look at TTG, very important. If a colonoscopy has not been performed, clearly if a person has diarrhea, it's very reasonable to do this, but important to obtain random biopsies to exclude any underlying inflammation. Bile acid CCAT test is very useful, particularly in IBS diarrhea. And there is new evidence with these antibodies, the anti-CDTB and anti-vinculin antibodies, that has a role in difficult diagnosis. Again, I'm a little cautious and guarded about its actual clinical role or widespread role yet. Then IBS-C, clearly, if it is severe or medical refractory, you really want to consider physiological testing. But in the mixed group, in addition to the diarrhea diagnosis, maybe you should consider doing a plain abdomen film to look at fecal loading. So what are the key mechanisms, particularly in that patient that we talked about at the beginning, who had features of abdominal pain, straining, constipation, and perhaps a touch of bloating? So here we have 5 main approaches. We have pro-secretory agents. We'll talk about linaclotide, lubiprostone, plaquenitide. There's a new agent, tenapanor, which is a hydrogen potassium exchange agent. We have fiber bulking agents, stimulant laxatives, osmotic laxatives like PEG, which, as you know, this patient did not benefit from, and antidepressants such as SSRIs. So let's talk about some of these agents. First, linaclotide. What is this compound? It is a synthetic amino acid, 14-chain amino acid, that when you take orally, it will latch itself specifically to the guanylate cyclase C receptor in the intestinal lumen. So linaclotide attaches itself to this receptor. When it activates this receptor, it then releases an active moiety by conversion of GTP to cyclic GMP, which is the active moiety. The cyclic GMP then diffuses out of the cell, and as it's diffusing, it has 2 broad mechanisms of action. One, it works on one of the chloride channels, again in the lumen, called the cystic fibrosis transmembrane conductance regulator, CFTR, releasing chloride into the gut lumen. When the chloride channel is opened, chloride goes out, bicarbonate goes with it, and then the gut lumen becomes much more hyperchloremic. So to try and alter that, water and sodium are pumped in a paracellular pathway, and now you get a rich secretion of chloride, bicarbonate, sodium, and water, which in turn distends the gut lumen, leading to peristalsis and thereby improvement in constipation-related symptoms. That's action number 1. Another action, interestingly, that has been demonstrated in animal models is cyclic GMP diffuses on the serosal side, where you have a number of nerve fibers, particularly in the IBS patient, you have very sensitized afferent nerve fibers, and it is believed that cyclic GMP will actually numb these fibers based on animal experiments. But there has been no such study in the humans. So does it really work? Well, here is the evidence. In this randomized large control study, there were 2 studies done, one I led, another one Bill Che led. And this pivotal trials, you can see when compared to placebo, there was a delta of approximately 20 delta in responders who had to have more than 1 complete spontaneous bowel movement per week, as well as 30% reduction in worst abdominal pain. So there was significant improvement, which then led to approval of this drug. But the question is, how does this drug actually improve abdominal pain? Now, we can understand the secretagogue effect and improvement in constipation symptoms, but what about pain? So to more understand this, we did a very novel study just published in the APT as of last month, where we placed a probe in the rectum, stimulated the anal and rectal region, particularly the rectal region, and then we placed electrodes on the scalp of IBS patients and picked up what we call as cortical evoked potentials. So rectocortical evoked potentials as a method of studying how the gut communicates with the brain. We did the same thing in patients who received placebo as well as IBS patients. We took a really hardcore patients with visceral hypersensitivity. Here are some examples of the cortical evoked potentials. In the placebo patient before and after, same individual, you can see this key response, which is the N1 response, is almost identical before and after the drug. In patients, however, this is the baseline response. Post-response, there is a significant conduction delay. So there is both the magnitude of response becomes smaller and the time it takes for the response from the gut to reach the brain is slower, indicating that linaclotide is somehow blocking the afferent messages from the gut to the brain. Here is the overall latency numbers, and you can see there is significant increase in the linaclotide group and not so in the placebo group, both for P1 and N1 latencies. Also, we found a significant improvement in the distensibility of the rectum in the linaclotide group and not so in the placebo group, further making the case that by decreasing hypersensitivity and decreasing how the messages go to the brain, that's how linaclotide actually improves abdominal pain in these people. Now, plakinetide is another GCC agonist, a sister compound, if you like, and even that in controlled trials at 3 milligrams a day has been shown to significantly improve IBS-C symptoms, very similar to linaclotide in very many respects, although the manufacturers here claim that it has a lower side effect of diarrhea, which is one of the main side effects of linaclotide. The other drug that I would like to leave you with is prucalopride, although only small anecdotal studies have really tested this in IBS patients. But in my clinical use and also in my use, I find this prokinetic as very helpful. As Pratik mentioned earlier on, this is one of the safest prokinetics we have. It is very safe on the hERG channels. There's virtually no cardiac toxicity. And I think it is a very safe agent for treatment of constipation symptoms. And the pivotal studies by Camilleri and Quigley clearly show that this is very superior to placebo in improvement of constipation symptoms. So that's my brief on the constipation side. Let's move on to the other story of another 25-year-old lady, long history of abdominal discomfort and diarrhea, also a touch of bloating. The diarrhea varies from 0 to 3, sometimes mushy stools, sometimes very loose stools. She also has excess flatus. Mother also had similar symptoms. She's a very high achiever in school, and she gives a history of gastroenteritis just before the onset of these symptoms. Exam was largely unremarkable apart from a slightly distended abdomen. So what are you thinking in terms of differential diagnosis? I mentioned earlier on bile acid diarrhea, something you should be considering. Well, does this lady has microscopic colitis, celiac disease? Could she have non-celiac wheat intolerance? Is there some other food allergy, or there is disaccharidase deficiency? These are some of the things that you should be thinking in your differential diagnosis. Of course, in India, you will be suspecting any infective conditions, parasites, and other causes which you have excluded already. So now, what kind of treatment options do we have for this? Well, we have a number of options that we can think. How about modulating the gut flora? We have two options to think about: rifaximin, the luminally acting antibiotic, or probiotics. Then if you have bile binding agents such as cholestyramine, cholesevelam, and so on. Then you have antispasmodics and peppermint oil. We have a serotonin antagonist such as elocitron and ondansetron. Then more recently, we have some of these opioid receptor modulators. Loperamide, of course, is an old drug, but more recently are really the iloxordelene compound. And lastly, the role for antidepressants, both in IBS-C and IBS-D. So let's look at these in turn. And we take an evidence-based approach. We look at some of the guidelines and ACG that really went through this. And what you can see is for loperamide, the recommendation is strong, but the quality of evidence was very low. For antispasmodics, again, the recommendation is weak because the quality of evidence is low. Now, that does not mean that antispasmodics don't work. The challenge with antispasmodics is they don't work in the long term, and there are very few good long-term studies. They work in the short term, and so it is reasonable to use it as a short-term or intermittent PRN use therapy. That's my views. Let's talk of probiotics. Now, there's a lot of hype, a lot of talk about it, and this is a topic in its own self. But in this ACG monograph, they felt that the recommendation was weak and the quality of evidence was low, but yet it is still one of the most popular things, not only in India, but all over the world. And the AGA just came out with its guidelines fresh, just less than 3 weeks ago. And this is the three main take-home messages from this AGA guidelines. Number one, insufficient evidence to recommend probiotics to treat C. diff infection, where I tend to use it too, Crohn's disease, ulcerative colitis, or IBS, the topic of my discussion. Number two, patients should consider stopping probiotics because of associated costs, and there is insufficient evidence for lack of harm. So they're not saying there is harm, but the evidence that there is no harm is not there. So that's what they're recommending. Number three, AGA currently recommends probiotics only in clinical trials. So we really need more data to convince us that this can be helpful and beneficial for IBS, and if so, which kind of IBS patients. Regarding 5-HT3 antagonists such as elocitron, this is an effective agent and works with IBS-D, but unfortunately caused ischemic colitis, caused some deaths, and therefore withdrawn by the FDA, reintroduced again a few weeks back in a risk mitigation program. And again, you can see that the incidence is very low for ischemic colitis and serious complications. We now use it, but use it cautiously only in women under the age of 65. Let's talk about rifaximin and its role in IBS diarrhea. This was a very large study called Target 3 study, and this was mandated by the FDA before they would give it approval, because the initial study, Target 2, suggested that rifaximin can be useful in IBS diarrhea. So here what they did, they took about 2,500 patients. Everybody got rifaximin as to start. Then about 44% of this responded to this drug. Now let's see what happened. About 36% of this group, it's about 1,000 patients responded in the open label treatment. 382 of this 36%, they did not have any further symptoms over the next 18 weeks, which was the follow-up period. But 59, about 60% of this group of 1,000 patients had a relapse of symptoms. These were then randomized in a double-blind phase to rifaximin 3 times a day or placebo in an equal number. So this was a very complex study design. That's what happened. So then let's see what happened. If you look here, and when they took the least observation carried forward, there was a statistically higher response rate, both in the first repeat treatment and the second repeat treatment with the rifaximin. Although the delta is about 7 to 8, it's not the biggest delta, but nonetheless, the symptoms of urgency, bloating, abdominal pain, and diarrhea improved in this second retreatment trial, based on which FDA approved rifaximin for treatment of IBS diarrhea. Iloxordelin is a new compound. It's an interesting opioid. It has effects on mu and kappa opioid, where it's an agonist, and it also works on delta opioid as an antagonist. So it's a mixed opioid drug. And is it useful? Yes. In large placebo-controlled trials at the 75 milligram twice a day dose and the 100 milligram twice a day dose, there was significant improvement of iloxordelin over placebo in the management of IBS diarrhea. Finally, about antidepressants. Now, we use them in clinical trials. The challenge with IBS, with antidepressants, is which one, how to target it, how to manage this, because we are not trained as gastroenterologists in these drugs. So you need to become familiar, perhaps with 2 or 3, like the tricyclic antidepressant class, the SSRIs, and so on. I tend to really use like sertraline or Lexapro for IBS constipation patients, because they are not constipating agents. And then in IBS diarrhea, I would either use nortriptyline or amitriptyline, and sometimes even trazodone for their management. There is evidence to support them in clinical trials there. Lastly, let's talk about dietary management. It's very popular now, particularly FODMAPs. What are FODMAPs? These are certain foods that are fermented, and maybe some patients cannot ferment or have challenges with fermentation, and therefore they experience significant IBS symptoms. The FODMAP stands for fermentable oligo-di-monosaccharides and polyols. So you have fructose, fructans, wheat and rye, lactose, sorbitol, and raffinose. These are all the common FODMAP food compounds. The evidence here is the US randomized control trial. Unfortunately, this was a negative trial in terms of overall improvement. But if you pick on some symptoms, abdominal pain and bloating scores, they did decrease. Although this was a better done study, although the studies from Australia, which are smaller studies, they show more improvement. Here was an interesting study about gluten. And although patients talk about gluten as a cause of IBS, it is important to recognize if they have celiac disease, that's a different disease altogether. But if they don't have celiac disease, then we're really talking about fructan, which is the sugar in wheat, as this intolerance. So when we talk of non-gluten enteropathy, what are we talking about? Really fructan intolerance. And in that group, if you really eliminate fructan, then I think there is some definite relief and improvement of symptoms. Lastly, psychological therapies. There are a number of modalities. These are time consuming and they're really compliance dependent. So patients have to comply with CBT, hypnotherapy, and dynamic psychotherapy. If they can comply with this treatment, you have a good psychologist who can administer it. Really, these treatments can be very effective in the management of these patients. So moving on, the final part that I wanted to very quickly talk about is really about bloating. Very quickly, this is a 67-year-old engineer with a history of Raynaud's, GERD, joint stiffness, but also significant bloating, diarrhea, denies any blood, was taking lansoprazole with good relief of GERD symptoms, a lot of testing done, really no cause for this recurrent bloating and diarrhea. So So we performed a standard glucose hydrogen breath test. You can see the time axis on the horizontal, the rise in hydrogen levels being shown in parts per million. And about an hour into the study, patient develops diarrhea and bloating, and there's significant elevation in hydrogen, indicating a positive glucose breath test. And this patient has small intestinal bacterial overgrowth, or SIBO. So what is SIBO? It's presence of excessive number of bacteria and a fungus in the small bowel, causing symptoms of gas, bloating, distension. And the way you diagnose it clinically is with the help of a positive breath test, such as glucose breath test, or by aspirating juice from the small bowel with a colony count of more than 10 to the power of 3. So I'm just going to very quickly summarize the ACG recommendations for SIBO, once again, just published in the last couple of months. So these are the top highlights here. Again, the evidence for supporting a lot of the SIBO literature is low, and that is how it is. Diagnosed SIBO, ACG suggests the use of glucose and lactose breath test for IBS. The evidence is low. For patients with suspected motility, it is low. For gas bloating, again, low evidence, conditional recommendation. Asymptomatic patients on PPI, do not test them. Whether to test for methane, right now, it's conditional evidence. But when it comes to treatment of SIBO, ACG recommends the use of antibiotics in symptomatic patients. It is a conditional recommendation with low evidence. What are the recommended agents? There are a long list of agents here, rifaximin, amoxicillin combination, and the efficacy is here. But please beware that when you talk of trimethoprim, sulfamethoxazole, 95%, there's only one study showing this efficacy. So you need to be guided with this efficacy. I would not use this in your management guidelines, but really think about these drugs potentially as useful in the treatment of SIBO. So let me conclude with this main takeaway. IBS, the main challenge is taking a good history. If you don't get a history, you're unlikely to make a good diagnosis. So digital labs can be very helpful. Pathogenesis, think about hypersensitivity, brain-gut dysfunction, as well as some epigenetic factors and psychosocial factors. You can diagnose IBS confidently in your clinic setting if you have good history and you use the Rome criteria to guide you. But you will also have to make sure that there are no alarming features and no other mimic. IBS is the greatest mimic of all GI problems. So make sure you take a simple tests like celiac, serology, etc. But biomarkers are evolving. There is emerging evidence for the role of diet, particularly low FODMAP, fructose, lactose, or fructose-free diets. Finally, we have good evidence now that a number of treatments work for IBS diarrhea, particularly 5-HT3 antagonists, tricyclic agents, rifaximin, iloxodilene, IBS-C, linaclotide, placanatide, procalcipride, lubiprostone, and SSRIs all can be effective. And lastly, antispasmodics and hypnotherapy in highly selected patients. Thank you very much for your attention.
Thank you, Satish, for a very nice deliberation. If I take all the questions, we'll be sitting around for more than 1 hour. What I've done is that I have segregated the questions into different aspects of your talk. And can we start with the pathogenesis? And you talked about various hypotheses for the pathogenesis, including visceral hypersensitivity, brain-gut axis, microbiota. So which is more important? And are these pathogenesis anything with the phenotype of the IBS? So is one particular pathogenesis more likely to give to one particular phenotype?
Very good question, Mahesh. I think the key pathogenic feature is hypersensitivity. There is something that changes the nerves, muscles in these IBS patients and how this information from the gut is being sent to the brain. So from a pathophysiological perspective, I believe that I think is the key mechanism. Now, how that mechanism comes about is the unclear component, whether it is epigenetic, it is a genetic, it's a phenotype of an individual, whether there has been some previous infection, something that has triggered it, or there is altered microbiome. These are all the other factors that may play a role. But the key feature is hypersensitivity and altered signaling between the gut and the brain.
Okay, about the clinical aspects, there are a number of questions which have been raised. Dr. Ashish Gandhi wants to know that with Rome 4 classification definitions, we have removed discomfort from the definition. But we do in our day-to-day practice come across patients who have just discomfort and we cannot call it pain. So how do we define this group of patients?
I think the important thing really was, particularly, remember the Rome criteria were never really designed, Mahesh, for clinical use. They were much more designed for research use and for clinical trials. What we found was that patients being enrolled with Rome criteria in Australia versus India, they were using different criteria. And therefore, discomfort became a very challenging a symptom for patients to define. Large validation studies were done, and they found it was a very poor discriminator for symptoms in these people. And that's why it was taken away. But in clinical practice, you're right. Patients do describe discomfort, patients do describe bloating, and patients will describe pain. I don't think you should dismiss somebody having discomfort as not having IBS. I would consider IBS diagnosis in them as long as they have the associated features, like they have an altered bowel habit and so on. It is acceptable to use discomfort in a clinical diagnosis setting, but not for research.
So there are two more questions related to the clinical profile. One is about the upper GI symptoms in patients with IBS. We often see patients having dyspepsia or other upper GI symptoms. So what's the significance of these upper GI symptoms in patients with IBS, and how does it implicate the management? And the second question related to, again, is are we able to characterize all into various phenotypes you talked about? We often have patients who say that he have incomplete evacuation. And so he goes to the loo 10 times in a day. So which group, where will you put these? They are just saying that each time they would go and they will pass a small amount of stool. They have a feeling of incomplete evacuation, but they will go about 10 times in the whole day.
All right. First question, overlap. Very important question, by the way. There is a significant overlap in patients with IBS. And Pratik mentioned earlier on about chest pain. So we did a prospective study of 100 patients who primarily came to see us with chest pain in the study of non-cardiac chest pain. We found that 80% of them had other symptoms, whether it's functional dyspepsia, functional constipation, bloating, IBS. So there is a multifactorial overlap, largely because this hypersensitivity is throughout the gut, because it's the enteric nervous system as a whole that has become hypersensitive. So yes, there is overlap in these institutes. Now, regarding the second case that was brought up, an individual coming with the 10 bowel movements a day, that individual does not have IBS. What I think is the problem there is that individual has incomplete evacuation and has an evacuation disorder. He or she may have some bloating and gas with it, but the primary problem is incomplete evacuation. That is why that poor individual has to go so many times to empty. So there is a defecation disorder, most likely dyssynergic defecation, where unbeknown that individual is obstructing his or her own passage and not evacuating completely, thereby leading to stool retention and multiple call or desires to go and empty. So that is dyssynergia, not IBS.
So while on the clinical profile, is weight loss uncommon or unheard of in IBS? So can IBS patients have weight loss? And when you talk about red flag sign, is the duration of symptoms also important as a component of red flag sign?
So I think, weight loss does occur in IBS patients, but usually very small amounts. 5 to 10 pounds weight loss, about maybe 2 to 4 kilograms is acceptable. But if there is much more profound weight loss out of proportion to the patient's habit, then you really have to be very alarmed about calling that IBS. So I'd be very careful, because now patients try a number of fad diets and a number of things. Some people become too anxious and they're not eating. That can all contribute to weight loss. But if weight loss is a predominant feature, please don't diagnose IBS. You have to hunt more carefully for some occult disease that is masquerading as IBS. So be careful.
What about gastrocolic reflex as a component of IBS?
It can be. We all have the gastrocolonic response. When we eat, the colon becomes active, and depending on the calorie content of the meal and so on, the activity can vary from anything 1 to 4 hours. It's a normal response that we all have. What is happening in the IBS patients is this response may be partially exaggerated, but more importantly, because they are sensitive or hypersensitive, they feel this. Whereas you and I, in whom the same mechanism is happening, we don't feel it. So it is not necessarily exaggerated, but it's actually more perception is changed in these people. Although in a small number of patients with the IBS diarrhea, they will have an increased gastroclonic response leading to diarrhea immediately after the meals. So that I think has to be, ascertained carefully and really tested and treated.
Satish, you talked about various modality for the constipation or diarrhea. If you have all the modalities available, what will be your algorithm? So if you have linaclotide available, you have prucalopride available, which one will be a drug of choice for the constipation as well as for diarrhea? And people also want to know that if you are starting rifaximin in diarrhea predominant IBS, what's the dose and the duration?
Let me take the rifaximin first, because that's more fresh in my mind in your question. So I think the recommended treatment for rifaximin is 550 milligrams 2 or 3 times a day. And I would probably comfortably start with 550 milligrams twice a day for 14 days. That is for IBS diarrhea. And that's the clinical trial where, of course, 3 times a day was used, but I think twice a day is usually reasonably effective. Now, with regards to your other question about which, in a constipated individual, which drug I would try, I usually don't have a magic drug for any patient. I tailor it to the individual patient and their patient's needs. That's the first thing. The second thing is, if the patient's already tried those medications, there's no point in trying them again because the individual's already failed. So I would take that part of the history into consideration before trying. The third issue really is, what are the coexisting symptoms? For example, if a patient has a much more diffuse dysfunction, symptoms of gastroparesis, symptoms of bloating, symptoms of constipation, then I may prefer to use a pan-prokinetic agent such as prucalopride. On the other hand, if a patient has nausea as an important component of their illness, I would not give them lubiprostone. If they don't have nausea, if they have bloating and pain as an important component along with altered constipation, then linaclotide or placanatide would be my drug of choice. So I try and look at individual symptom profiles, the previous use of drug, and then try and tailor the drug to their needs accordingly.
Linaclotide is not yet available in India. Should we really looking for it? Is it going to change our approach to IBS totally?
I think it will change your approach to IBS significantly. I think it's a very useful drug. It's a completely different mechanism of action. One of these, generally though, the good thing that is happening in drugs as a whole is these are all luminally acting drugs. So they have a very good safety profile. They act in the gut where the problem is, and they don't have a systemic effect. So that, I believe, is a strong advantage of drugs like linaclotide, placanatide, even lubiprostone, and also rifaximin. So these are the first generation of GI-specific drugs. So I'm quite pleased really to advocate those drugs because of their gut-specific action and lower risk of both drug-drug interactions and systemic adverse side effects.
So I'll take 3 more questions. There are many more, but I'll just pick up 3 important questions. What is about prucalopride? You talked about 1 milligram, 2 milligram, and 4 milligram in the study. What should be the ideal dose? Does the age decide the dose as well? Is it safe in individuals 70 years or 75 years old? And how long can we keep this drug? So that's the first question.
All three are very, very excellent questions. So first of all, I always tend to start with a very low dose. I usually start with 1 milligram a day because its main side effects really are diarrhea, headache, and nausea. So that sometimes can be very troubling for patients. So I usually start with 1 milligram a day. I'll then double it to 1 milligram BID or go to 2 milligrams BID if it's not effective. There's no harm in starting them. Secondly, if a patient is significantly constipated, I try and make sure that you've cleaned the bowels before starting the drug. If the patient is constipated, do not start prucalopride on a loaded colon. So that's important. Third, as far as elderly use, I use it in elderly patients. It works very well. There are at least 2 very good studies of prucalopride in older individuals showing its safety and efficacy. And again, I will start with a low dose of 1 milligram a day.
So if there's a question about constipation app diary, which you talked about, is it freely available? Is it you need a password or something to open the diary?
So I don't know, Mahesh. I'm told by the developers that, we've done all the validation, everything. They said it's available, or maybe I think July 1, it's going to be released. The fecal incontinence app, I know it's available and has been available for several months. But the constipation app will become available very, very soon. It's a very simple app, and I think it can be very useful for patients. It can be very useful for physicians to monitor symptoms and also monitor treatment.
So Adish Jain, the last question from my side, and Adish Jain has asked you, is it curable? IBS, is it curable? Do you have patients whom you give a treatment for a well-defined period and they are fine for a long rest of the life?
It's a very good question. I think, I would not think IBS is curable at this stage unless you've defined a mechanism. Let's say, for example, patients have come to me with significant diarrhea, gas, and bloating, and then I've identified either SIBO or I've identified fructose intolerance. You take away fructose, their symptoms are gone for life. But that is not in everybody with IBS. I would say that would happen in about 60% or so of my patients, but about 40% of my patients, we're not able to identify clear mechanisms that are treatable and curable, and therefore we'll have to really treat them lifelong with their problem.
Thank you, Satish. I think we'll have to wind up from the questions. There are many more questions, but I'll pass on to Nageshwar Reddy for the final comments. Nagi.
Thank you, Mahesh. Great.
Thank you, Mahesh. I think we have had two fantastic lectures on a common bread and butter problem for us gastroenterologists, and by two masters in this area. Pratik started with GERD, telling us about the unmet needs in these patients, the new endoscopic techniques that are coming up, the dual release PPI that is the basis for what it's used for, and of course the bile acid sequestrants. More important, I think the most important point he made was those who are not PPI respondents don't respond to surgery. Surgery is not indicated. We've had a very good summary of what is happening in this field. Thank you, Pratik. And then, of course, we had this masterly talk from Satish on irritable bowel syndrome. Again, extremely common clinical practice. He emphasized on the history, the digital app, which is probably going to come very soon for the digital diarrheas the patients can maintain. The importance of visceral hypersensitivity in these patients. I think this is, again, very important. He talked about various mechanisms of therapies, including linaclotide and, of course, the newer therapies that are coming in. The role of rifaximin, and, of course, the lack of use of probiotics in these patients, and emphasized on where we should use the breath test. I think these are two very important talks that have actually enhanced our ability to see and treat our patients. I'd like to thank both of them, and, of course, my co-chairs, Randir and Mahesh. Thank you very much, all the colleagues, for joining us for this. And, of course, like to thank Sun, Joseph and Salil and his team for coordinating all these efforts. Thank you very much.
Thank you, Nagi. Thank you, Pratik. Thank you, Satish. And thanks.